Good morning, everybody, and thank you for being here on this beautiful fall morning. And I'm excited for today's presentation. We have an interesting application that's a collaborative effort between three departments, the Department of OBGYN, Global Health, and Computer Science. And our presenters will include Dr. Lisa Harrington, who's an assistant professor in the Department of OBGYN, has worked a long time in many different settings, including in Kenya for the past many years. And then Lisa Orii, who's a PhD candidate in the Department of Computer Science and Engineering, works with Dr. Richard Anderson, who's retired, but has actually helped WACh with a lot of different apps, co-developing things with the computer science department. So it's exciting just to see the interdisciplinary nature of this application and talk, and we'll hear more about it. And so excited for you to hear it. Welcome.
Thanks so much, Grace. Both Lisa and I are really excited to have this opportunity to talk to you about our collaborative work with Emory today. And I wanted to start with a land acknowledgement for those of us who are in Seattle right now. We acknowledge the land we occupy today as the traditional home of the Tulalip, Muckleshoot, Duwamish, and Suquamish tribal nations. Without them, we would not have access to this working, teaching, and learning environment. We humbly take the opportunity to thank the original caretakers of this land who are still here. And with that, we wanted to start with some thanks, Grace, for those introductions, and we just wanted to provide a bit of introduction for both of us and some positionality. And I'm Liz. I hold a variety of identities that shape my work. One of those is being a clinician. I'm an OBGYN and a complex family planning specialist. I'm also based here in the US. And I've been working on collaborative research and clinical programs in Kenya since I was a medical student. And so it has been quite the learning process, but have some lived experience in Kenya, but am based in the US. And then I wanted to have Lisa introduce herself.
Hi everyone, I'm Lisa Orii. I'm a PhD candidate in computer science here at UW. My research focuses on designing user-centered digital health tools in low and middle income countries. And I try to position myself between technologists who are actually developing these tools and health researchers who have the vision for these technologies and try to help translate ideas and concepts between the two groups. I'm also looking for full-time opportunities in digital health and global health. So if anybody has leads or connections, I'm happy to talk after. Thanks.
Thanks, Lisa. And we have, we'll make sure we end with a slide with Lisa's email so that you can shoot her any opportunities that you see. And I know this crowd is very well versed in the barriers to sexual and reproductive health access among adolescents around the world. But just wanted to kind of frame our conversation today with the fact that there are kind of different categories of barriers that are quite well documented in the literature and have actually kind of borne out in our own formative work that I'll talk about. But the categories of barriers to accessing contraceptive as well as other kinds of care include laws and policies that restrict youth access. They also can lead to a chilling effect in care seeking. We see gender and social norms that create stigma for youth. Those are really key for contraceptive care. Limited health literacy and financial resources, privacy concerns, and a variety of other health systems barriers. And we know that specific context matters quite a bit, but these barriers are definitely present for youth in Kenya. And I always like to just mention that there is kind of like as in many countries, there is a challenging kind of confusing landscape around the law in Kenya, where the 2019 reproductive health care bill in Kenya requires parental consent for contraceptive and other sexual and reproductive health care. But that's not really consistent with some of the policies that are also in effect. So it's just kind of it can be confusing and have a chilling effect. And I'm going to be introducing you to sort of our research journey of the Mara study today. And that has been a collaborative suite of studies led by the UW and KEMRI, or Kenya Medical Research Institute. And we named the study Mara because the word means, or Professor Bakusi came up with this. Mara means mine or my own in the Luo language, and we wanted to really center the ultimate goal of advancing person-centeredness and autonomy in adolescent reproductive choices. And person-centered care, I would say the field of family planning has been moving in this direction to kind of prioritize and privilege person-centeredness in care. And it refers to care that is responsive to an individual's values, needs, and preferences. And studies have demonstrated that when people's values and preferences are attended to in their contraceptive counseling and care, that they have better outcomes, they are more satisfied with their care, and also more likely to continue their method as desired. And also, it's kind of like a no-brainer. It's like ethically the right thing to do is to provide care that's non-coercive and centered around people's values. So we grounded our work for the Mara Divas App in the human-centered design process. And so I'll kind of keep coming back to the slide and how we used this process to create insights for our users. But this process is characterized by a focus on building empathy with potential users with specific lived experience that you're interested in. And then iterative idea generation, where you are kind of iteratively ideating, then refining and testing your ideas and improving them over time. And in this case, Lisa will share how prototyping the Mara Divas app then led her to circle back to the ideation process and develop a potential chatbot solution. So it's also well documented that unmarried adolescents and youth, especially those experiencing social and financial marginalization, frequently source their contraception from community retail pharmacies. And our formative work, we decided to set our work in the pharmacy setting for that reason. But we've also highlighted that the inherent limitations of the pharmacy as being a business and maybe providers not being kind of having the same access to training as some of the facility providers, that person-centered contraceptive counseling is not consistently available in that setting. But we do know that many adolescents go to this setting due to kind of feeling like the stigma is less, or they're more able to keep their care private, or it's more convenient related to their kind of daily activities. So I'm not going to spend a ton of time going through all of our formative work, but we did do quite a few we used quite a few different methods to really empathize with potential users. And those included both quantitative and qualitative studies. One kind of way that we actually directly used in the app development was a discrete choice experiment where we used to prioritize adolescent preferences around different contraceptive method attributes and service delivery attributes. And I'll kind of explain a little bit about how we used that. We also did qualitative interviews with adolescents and a mixed method evaluation of contraceptive care in pharmacies, where we used mystery clients and also some like on-the-ground process mapping to try to understand the experience of accessing contraceptive care in the pharmacy and what some of the pain points were. We found that, as I was mentioning earlier, that pharmacy providers have a strong desire to serve adolescent girls and young women in the pharmacy setting in their contraceptive care, but frequently lack the time and the training to do so the way that they would choose. We concluded that youth need access to person-centered care in low-barrier community venues. And as we started to ideate potential solutions to this, we were really inspired by an app, or it's a web-based application called My Birth Control that was developed by the UCSF Person-Centered Contraceptive Care Program. The PI on those studies is Christine Dellendorf, and you may have heard her speak or read her work. But we're really interested in this idea that in the absence of a trained provider, maybe a harm reduction approach would be to have a digital health contraceptive decision support tool that would help adolescents get the information they need prior to choosing their method in the pharmacy. Okay, so this is our amazing collaborative team. Richard's here. Lisa is obviously here. And my main Cambry counterpart on this study is Sarah Gitome, who has extensive experience in human-centered design and really led the the participatory workshop portion of our work, which I'll discuss in a moment. Nelson Cheruyat was a design consultant who worked with us on the app development and the co-design process. And then Lisa, mentored by Richard, really took the lead in actually developing and building the app, and she is 100% credited with operationalizing this. She worked with 5 undergraduate students to build the app using, they received research credit, and it was just amazing to see this process come together. Okay, so after we decided to try the app solution, and our idea was that given our prior research that adolescents in our DCE, which is a discrete choice experiment and kind of a 500-person survey where we did community-based recruitment of adolescents 15 to 19, we found that at least half of them didn't have their own phone, and far fewer than that had their own smartphone with regular access to data. So we made a kind of a choice that definitely has implementation, consequences, but we decided that we were going to have a tablet-based app that would be physically in the pharmacy for adolescents to access when they went to the pharmacy. So that was kind of an early decision that we made because our main goal was to try to reach that more marginalized cohort of young people. And so in the ideation process, we started creating wireframes of the app in Figma, and that was quite a learning curve. But it ended up being really helpful when it came time to actually build the app and be able to refer to different screens for the technical team, which was that Lisa led. So this is just a screenshot of some different wireframes that we created as we started to develop the app content. And then now I'm going to just briefly take a deep dive into our prototyping process, which was primarily co-design workshops with adolescents and who are aged 15 to 24, and also a group of pharmacists who provide care to adolescents in the pharmacy. We created some different features of the app based on our formative work that we then tested out in the workshops. And our key app features really include content tailored for their priorities. And so this is the home screen on the left. This is kind of the final version of the home screen. It had a variety of different iterations, but we ordered the information based on kind of the level of priority that adolescents gave the information in the DCE, as well as in our kind of empathy building previous work, primarily qualitative work. So for example, bleeding pattern was one of the most important things to adolescents about their contraceptive method. And we put that very high up on the home screen so that people would be able to see that and learn about it. And then we also wanted them to be able to find and review the information that was most relevant to them. So our assumption was that they probably wouldn't get through all the information, but they would be able to choose what they were interested in. And then we also, the app is multilingual, and so you can change the content is available in English, Kiswahili, and Deluo, and you can change the language by screen. And also we created a variety of videos, and we can take a look at this maybe after the presentation. Anyone who's interested, I think in the interest of time, I'll skip it, but we did create 7 different videos using kind of peer stories, and also some Kemery volunteer nurses were our actors, as well as some peer actors. And those just kind of describe experiences with different contraceptive methods, different side effects and how they managed them, etc. Okay, and then in the prototyping phase, we use community-based recruitment strategies to engage adolescent girls and young women aged 15 to 24. We used snowball sampling and peer leaders. And then the participants had access to contraceptive method in a pharmacy in the last few months and were not currently pregnant. We also recruited pharmacy providers for a separate workshop. And the workshops were full-day participatory workshops. Yeah, we did a variety of different design activities like journey mapping, role play, group interview. We did app engagement with structured feedback. Lisa was present and led some usability testing with the adolescents. And then between each workshop, the design team requested modifications, and the technical team would start to refine that, and we would have a new prototype to test in the next workshop. And I'll just share briefly a few of the insights and how we modified the prototype. I think I'll just mention this one because in the interest of time, I really want to make sure Lisa has a chance to talk too. But one thing that was really a key insight was that many of the adolescents who are coming to the pharmacy for emergency contraception, and that's a major method that people are seeking at the pharmacy, they're very anxious. They're like, they've already had the exposure, and they're concerned about pregnancy. And so it's not an ideal time for them to engage with an app about a variety of other methods when it's true that they really need one specific method, which is emergency contraception, and they've already had it's already happened, basically. They're already at risk. So we found that, and this was through both the providers, and they used the term rocket speed to describe adolescents and how they move through the pharmacy. Basically, like any facial expression or question can sometimes make them like literally run away from the pharmacy. And so there's we're not gonna, a key thing here is that we're not gonna catch everyone, and this isn't gonna meet everyone's needs, but sort of how could we provide more of a hook for EC users who are coming in to maybe understand that you can start a longer term method at the same time as your EC, or you might learn more about how to use the emergency contraception effectively. So based on the insight from the workshops, we added some different buttons to the launch screen, basically allow them to bypass all other information and go straight to the EC page, where they can watch a video about EC use, and they can also learn, most people hadn't been aware that you could start Depo, or you could start another method at the same time as using the emergency contraception pills. And Lisa has some more to share about emergency contraception. And then we also just gleaned, I'll say briefly, we gleaned from the workshops that adolescents really want to see themselves as sort of strong divas, or kind of sexy, stylish people. And so trying to reflect that is important. And one group specifically said like this name is boring, you should add diva to the name. So we did. But that's only part of it. They had really strong opinions about like how the person should look on the options page, and sort of like, should she be wearing a crop top? And I'm saying that like it's kind of funny, but also like I think it really reflects how they want to see themselves, and I think we should be listening to that. And then it was very clear, I think it surprised everyone on the team to some extent, maybe some more than others, how little people wanted to read. The audio, I didn't mention this, but everything, you can click on an audio button next to the content and have it read to you. The videos were probably the most effective part of the entire app. And so we ended up doing quite a bit of simplifying of the text, which was just overkill. And if we have time at the end, I'll like the desire to be person-centered was kind of interesting, because at some of the adolescents at the end were like, can you just be more directive and tell me what method I should use? And we were like, what? That's not the point. But it is the point for you. So let's think about that. So we're trying to simplify things. Okay. I'm going to skip the feasibility study stuff, but basically we did test the app among 100 adolescents at 6 different pharmacies in Kisumu. Learned a lot about that process, and also learned a lot about like future implementation challenges that we need to address. And so I'm happy to answer questions about that later. Finally, which is kind of a I'm gonna hand it over to Lisa shortly, but I, especially in honor of Richard, I wanted to just mention that even though this is a pretty like high input app, like you have to have a tablet in the pharmacy, it's not like the most cheap intervention you could possibly consider. It has a lot of potential implementation considerations. Richard has done a lot of work in trying to make technology more accessible to global health practitioners. And one aspect of this app that we're really excited about is that it uses an open source platform for the coding. So Flutter is a Google open source, what would you call it, UI platform. Yeah. We have a lot of challenges with like terminology. Turns out, by the way, implement means something very different in computer science than it does in public health. And sometimes I had to be like, okay, so what does that mean again? Like, can you just remind me? This is just a screenshot of the app, the text on the app, and it was linked to the audio file. So it's just a Google spreadsheet, and Lisa and her team like coded it such that like we could translate this into a different language and swap out the videos and recreate the app pretty easily in a way. I know easily is in air quotes there, but that was the idea, that if it were effective in one context, you could actually adapt it and implement in another context. Take home points. I think what I'll just say is we learned that there are a variety of, and Lisa has written about this in one of her papers, that literacy, digital literacy, written literacy, language literacy, these are all really important to consider in working with adolescents. And we were surprised, given the high level of literacy in Kenya, especially, that like reading literacy was not something that was super easy for the adolescents that we were engaging in our workshops. And so just considering that in digital health development, I think it's really important to know your audience. And then always like to, sort of own that digital health innovations are really not, there's one piece of much bigger puzzle, and far from a magic bullet, but I think really trying to focus on reaching a more marginalized community is one area where digital health innovations can really be beneficial, kind of in the whole landscape of more horizontal health system strengthening that benefits everyone. And if we have time, we can talk in our discussion later about kind of the implementation challenges presented by the pharmacy setting, which I think are really interesting. And with that, I'm going to hand it over to Lisa.
So I wanted to talk a little bit more about some current and most recent efforts that I've been working on with respect to this project. So having led the technical development and also engaging in co-design, one of the things that I learned from this work was that this app has a lot of potential to facilitate decision-making. It really helped them kind of learn new things, and as a result, they also had new questions that were structured after using the app. And ideally, these questions would be asked to the pharmacist after app use, but because of various power dynamics at play, the adolescents really didn't feel comfortable approaching the pharmacist with these really sensitive and personal questions. So with that reality in mind, I thought maybe there is potential for another digital intervention, like a chatbot, to be placed in between the Mara Divas app and the pharmacist and sort of help facilitate another set of decision-making processes. But if we were to do that, how would we do that and what's considered good design? So in this work, I decided to take a pretty formative approach to exploring potential futures with chatbots. And the main reason I decided to take this kind of critical, formative approach is that there's a lot of technology that's being developed and sort of thrown into the wild right now, but I didn't really want to take that approach given how sensitive this context is, given just the population that we are working with. So I decided to apply this design practice called speculative design. And it's a really helpful tool for exploring implications of possible future scenarios, especially with newer technologies like a chatbot. And it's great for evaluating appropriateness and utility. But I think the point that's most relevant to this contest is this last bullet. It can help probe engagement even when participants are not familiar with these technologies. So just based on my learnings from the first set of co-design workshops, I knew that these adolescents had pretty varied literacy levels with respect to digital literacy and language literacy. So I did still want to make sure that even the girls who had never heard of a chatbot or even AI could engage with the idea of one and still be fully present and participate in these ideas. So I applied this speculative design practice by creating 3 different low fidelity prototypes of chatbots. And by low fidelity, I meant that they're not functional, but they're kind of just videos that we show to introduce the concept of a chatbot. And I positioned these prototypes as design probes. So something that will kind of kickstart the conversation or ideation and more in-depth discussion on what a chatbot could do or look like. And the 3 prototypes I created were based on the learnings I had based on, different digital and literacy language levels. So the first one is a text prototype, which is like ChatGPT. So this is one where the user types in a message, sends it in, and then the chatbot responds with text. So this one requires the ability to structure your questions, verbalize it with writing, type it out, and also the ability to read. So this might require some higher level of language and digital literacy. The second prototype I designed is called a buttons prototype, or something where you can kind of choose from a selection of options. So instead of requiring somebody to type out their question, this one just requires somebody to choose a button and sort of guide the conversation from there. But it still does require the ability to read. And then the third prototype I created was called an avatar prototype. So this one eliminates any requirement for reading or typing. It only requires the ability to listen and express your thoughts with voice. So this is showing a figure on a tablet, probably somebody who resembles a healthcare provider who's kind of engaging with the AGYW through speech and voice commands. And I created these designs using Figma, which is the same platform that Liz used for the wireframes for that. So I brought these 3 prototypes to Kenya this past April to hold some co-design workshops with the adolescents and the pharmacy staff. We in total had 4 workshops with 12 pharmacy staff and 36 AGYW. And we had 1 set of workshops with the pharmacy staff and 3 with the adolescents. And in this co-design, I wanted to pretend like we were in a pharmacy visit and kind of take us through each point in that visit. So in the early stages of the workshop, we would talk about what are some of the thoughts and questions or concerns you have before coming to the pharmacy? What is your goal in this experience? And then we introduced the Mara Divas App. So we prepared a few tablets, distributed those, and had the participants use the app just to set the tone for introducing the chatbot, which would happen after app use. And after showing the 3 different prototypes, we had participants reflect on what they just saw. Like, what are the similarities and differences you notice between the prototypes? What kind of interactions do you want to have with the chatbot? And participants would oftentimes write their thoughts on sticky notes, which I found was a really effective way to just engage ideas. So this one is a series of Post-its written by adolescents in response to the question I asked, which was, what questions do you want the chatbot to ask you? And at the end of the workshops, we had an ideation session where participants would discuss or sketch out some ideas on what they want an ideal chatbot to look like. And I really like this image because I think it captures some of the core characteristics that they want in a chatbot. So this participant wrote, I want it to have big ears because that means it's listening effectively, but I want it to have a small nose because I don't want it to be nosy. So I thought that was really clever, and I really like this kind of symbolism. But I think a lot of the sketches and ideas that came out of the ideation is reflecting what they also want in an ideal provider. So I did see some interesting contrast, especially in that session of the workshop. So now I'm going to share a couple key findings. The most positive outcome we're learning from all of this is that everybody pretty much agreed that chatbots were a great idea. They were like, this is going to offer a really safe space for us to ask very personal questions. And they tended to compare the chatbot to the pharmacist, saying that pharmacist tends to provide a lot of biased, judgmental opinions and views, but the chatbot's a lot more open than that. It's very non-judgmental, it's really unbiased. And this top quote by the pharmacist is pretty much a recognition that they are also biased and that sometimes they're not really giving out the best advice to these adolescents. And the second quote by an adolescent says, there's some doctors there, they usually say that the disadvantage of P2, which is the emergency contraceptive, you can find that some ladies can stay 3 years before they conceive. So they say that that can be a disadvantage of excessive use of P2. And I would prefer the chatbot to just be open and say that because I'm worried about that. So I think that quote really captures how they want the chatbot to be really open, like lay it all out there, tell me all the disadvantages and the advantages. And that's something that's really going to help them make an informed choice. And because there's such honesty with the chatbot, the participants thought that this is an opportunity to really build self-confidence and gain more knowledge. As this adolescent told us, you are more informed and you're like the expert now. You are not the way you came. And I like that quote because I think it shows that there's potential for interventions to kind of be an empowering tool, help them gain more knowledge. And this quote in particular was said in the context of, I will know more about contraception than the pharmacist will. And I think that was kind of, really interesting, but also eye-opening in a way that, this is something that could potentially have positive change. While there was obviously a lot of positive sentiments about the chatbots, there are also a whole host of challenges, naturally, as we might expect. And one of the challenges that I was really interested to find was in the tensions that were introduced by these chatbots, especially in the tensions between what these adolescents want from a chatbot and what the pharmacists want. And one of these tensions was in how much information is going to be provided. So the adolescents really wanted to ask the chatbot everything. They were like, there's nothing out of the bounds. This is an opportunity for me to ask everything and anything because I can't ask it to a pharmacist. But the pharmacists really wanted clear informational boundaries. They were pretty clear on what types of information they didn't want the chatbot to share. And we had a lot of time discussing this with respect to abortion. So they were saying things related to drugs or procedures, that's not something I want the chatbot to talk about with an adolescent. That's something that should be talked about in face-to-face counseling. Another tension we noticed was in privacy. The adolescents really wanted these conversations to be private, and that makes sense because they wanted to ask really personal questions. But the pharmacists actually wanted a lot of access to the types of conversations and questions that were happening between the chatbot and the adolescent. So in this left quote by the adolescent, they say, if it's going to be like ChatGPT, it has a backup. What if it reveals my name? What if the pharmacist has malicious intent and she finds out my details later? This particular adolescent had used ChatGPT before, so she was referring to it a lot, which is really interesting. And I think it shows that there are definitely a subset of people who understand how some of these technologies work. And hence the concerns are also there. But with this pharmacist, they say if the girl's not able to share it, I can also get it from a chatbot. That's the most suitable method for this kind of girl. So they're saying that if in counseling, this adolescent is too shy to share some information with me, I can just look at what they're talking about with the chatbot and help guide decision making. So this is said with good intentions. They're trying to leverage the chatbot as a tool that can help during the counseling process. So I've also been able to outline a few design guidelines based on the findings I had from the workshops. And with what I just talked about with respect to tensions and privacy, I think this is really difficult and interesting because the chatbots are intended to mainly support the adolescents. Like this is a tool that's intended for that. But because we're putting it in the pharmacy setting, I think it's really important to also get buy-in from the pharmacist and make sure that this is a tool that's accepted by these providers. And one way to potentially mediate this tension is for the chatbot to generate aggregate level FAQs to be shared with the providers. So this isn't exposing one-to-one conversations and sharing that directly with the providers, but more so saying, hey, here's a list of commonly asked questions that you might want to consider when talking with an adolescent during counseling. So I think this is one way to preserve the privacy that the adolescents want, but also giving the pharmacists what they want in a sense. Another thing that was really reiterated in this workshop was how strong community beliefs influence health information seeking and decision making. In this particular population or community, we found that they have really strong beliefs about the injectable contraceptive, for example. They thought that the injectable can lead to permanent infertility. And while that's not true, there's a little bit of truth to it because it can delay return to fertility. And the adolescents were telling us that they really wanted this chatbot to distinguish quote unquote myths from facts. So again, they wanted this to be very open and unbiased, really lay out the medical truth for them. But because these beliefs are so strongly and persistently ingrained into their communities, I think it's really difficult to just say, that's completely wrong. Like, let's just reject that idea and here's the truth. I think it's really important to kind of soften the blow in a way, and if anything, create opportunity to impact why those beliefs exist and like why and how adolescents think about these things. So more concretely, I think the chatbot should prompt these adolescents to ask about particular rumors or beliefs that they've heard. So saying something like, hey, what have you heard your friend talk about the injectable? Are you concerned about some of the things you've heard in your community? And sort of opening up space for the adolescents to discuss their concerns there. And the third design guideline I'm going to share is with respect to what type of information to share and how. So our Mara Divas app is built on evidence-based guidance and recommendations around contraception. But in this workshop, I found out that sometimes that's not exactly what the pharmacists tend to endorse in their settings. And we saw this with respect to emergency contraception. So with evidence-based management, I believe it suggests that you can take emergency contraception up until 5 days after unprotected intercourse. And that's what our app says as well. But the pharmacists actually recommend taking it up until 72 hours. And that's mostly because the pill packaging of the EC also shares that same recommendation. And I think in this sense, it makes sense for the chatbot to also share information that is consistent with what the pharmacist is saying. Like they're saying this with good intention to make sure that the adolescents really adhere to a safer timeline. And while this is an example where it does make sense for the chatbot to follow one type of recommendation, I think it's challenging to identify when exactly it's appropriate to follow and promote evidence-based management versus when it's better to promote pharmacist recommendations. And I think that is a whole set of challenges that come up in this type of intervention. I want to briefly share about some ongoing efforts that I'm working on after having designed and outlined those recommendations for chatbots. So I'm really interested in thinking about how exactly these chatbots can work with a functional prototype. So something that really works where you can ask a question and get a response. And understanding more of the potential pitfalls and risks in deploying these types of interventions. So I'm interested in building a chatbot of my own, using an existing model like the ones that we use for ChatGPT, and kind of exploring how, given a particular question, how would the chatbot respond? How does that differ from an expected tone or response? And does that fall within or outside of those design guidelines that I shared earlier? And I'm also interested in seeing how this could potentially work with other similar languages that don't have a lot of digital data. So Kiswahili is definitely growing in terms of digital data that's available, but Luo is still unavailable in many ways. So testing it out in similar languages and seeing what kind of learnings we might have could help us understand the actual technical feasibility of these types of tools.
Yeah, and I keep asking Lisa, like, but what if it spits out an answer in like formal Tanzania Kiswahili? Like, are people gonna understand it? She's like, it's speculative, Liz. It's, you know, if the future is not here yet. But anyway, just to think about next steps, we're actively looking for funding for additional research for the Mara Divas app, and so would welcome any ideas anyone has. Our R01 was reviewed and got a ton of great feedback from the implementation science study section. I resubmitted that with Dr. Gitome in October, oh no, sorry, gosh, February now, February of 2025. And it was supposed to be reviewed a couple weeks ago. That's on hold for now. So looking forward to hopefully getting a score on that. We also tried a smaller IDRC Canadian grant. We're not successful at that, but it was an interesting exercise in like trying to move more of an effectiveness trial into a smaller grant that was focused on refinement of implementation strategies. So we worked on that, and then I'm also it's a much more restricted budget than the R01, but also thinking about there's a mobile health in LMIC's RFA that's out currently, that's an R21, R33, so considering that as well, but would really welcome other ideas to continue to move this work forward. The R01 really focuses on refining implementation strategies for the app with stakeholders and uses continuous quality improvement and other participatory work to do that. And then we proposed an effectiveness implementation trial in Kisumu County. It's a cluster RCT at 22 pharmacies. So that's all of our prepared comments, and we'd really love to hear your questions and have any kind of discussion about these kind of